Hello friends, our topic now is kidney. The main group of drugs which act on kidney are diuretics. Diuretics are the substances which cause loss of sodium and water in the urine. If a drug causes excretion of only water in the urine, it is called as aquaretic. Like water is an example of aquaretic. If we drink excessive amount of water, more will be excreted in the kidney. So that is aquaretic. Whereas diuretics are the substances which cause loss of sodium and water in the urine. Now we can classify the diuretics based on site of action, that means where they act on the nephron. This is glomerulus, proximal tubule, loop of Henle, distal tubule, and collecting ducts. Diuretic can act on any part of the nephron. According to site of action, the diuretics may work on proximal tubule, they may work on loop of Henle, they may work on distal tubule, they may work on collecting ducts, and the diuretics may work anywhere. So 5 types of diuretics we will discuss. One which is non-specific, that means it can work at any place in the nephron. Second, which mainly act at proximal tubules. Third, which mainly act at loop of Henle. Fourth, which mainly act at distal tubules. And fifth, which act at collecting ducts. So one by one we will discuss these diuretics. We will start from diuretics which are non-specific. And this group of diuretics are called as osmotic diuretics. Example of osmotic diuretic is mannitol. So as the name tells, they act as a diuretic because of osmosis. Osmosis means water attracting property. So for a diuretic to act as osmotic diuretic, what should be the properties? The first and the most important property should be the drug should be freely filtered by the glomerulus. So if a drug comes in the glomerulus, in the nephron, only then it can attract water there. So osmotic diuretic should be freely filtered by the glomerulus. Second thing, the drug should not be reabsorbed, because if it is reabsorbed, it will go away from the kidney. So it should not be reabsorbed. Third, it should be chemically inert. It should not produce any reaction. And most importantly, it should exert the osmotic effect. So 4 important properties for a drug to be osmotic diuretic. Number 1, it should be freely filtered. Second, it should not be reabsorbed. Third, it should not react chemically. No chemical reaction. And lastly, it should exert osmotic effect. And all 4 properties are present in mannitol. So it acts as osmotic diuretic. The major use of mannitol we all know is cerebral edema. So how mannitol is beneficial in cerebral edema we will like to discuss. So this is our brain. This is blood vessel which is going in the brain. In cerebral edema, there is plenty of water in the neurons. So these neurons, they are loaded with water. Plenty of water is present in cerebral edema. Water is present. So when we give mannitol intravenously, along with the blood, mannitol will reach the blood vessels of the brain. Now we know that mannitol exerts the osmotic effect That means it will attract the water from the neurons. So from the brain water comes. Means if 100 ml of blood is entering the vessel in the brain, the blood which is going out of the brain from this vessel will be 120 ml. Means it has attracted the 20 ml of water. So when the water comes out of the brain, the edema subsides. Means the beneficial effect of mannitol in cerebral edema is osmotic effect only. Remember, diuretic effect has not come yet. The same thing mannitol will do in every organ. Means it will attract water from the organs, and this large amount of water will now be presented to kidney. Further, it will be filtered by the nephron and it will attract water there also. So that will contribute to diuretic effect. Means the beneficial effect of mannitol has already come, but the diuretic effect will come later. So the beneficial effect of mannitol in cerebral edema is osmotic effect. Similarly, mannitol is also useful in acute attack of glaucoma, particularly angle closure glaucoma. Now, one important problem. Suppose a person is having cerebral edema and the reason of edema is cerebral hemorrhage. Cerebral hemorrhage means the blood vessel has ruptured here and this rupture of blood vessel is resulting in edema. Now we give mannitol to treat the edema. So what will happen is, now mannitol, as it is filtered by the blood, so mannitol will come in the brain. Now because the blood vessel is ruptured, so mannitol can leak into the brain through this ruptured blood vessel. And we know mannitol exert osmotic effect. So when mannitol is present here in the brain, instead of decreasing, it will actually aggravate the edema by retaining water. So mannitol is contraindicated during active cerebral hemorrhage. During active cerebral bleeding or active cerebral hemorrhage, mannitol is contraindicated.
Mannitol is also used in incipient renal failure. So incipient means imminent renal failure, or you can say partial renal failure. So basically you can understand the concept. This is glomerulus. Normal person, it has very good glomerular filtration. Almost all the blood which comes can be filtered. So filtration fraction is very high. In renal failure, this fraction will decrease. Now suppose 100 ml of blood is coming. In a normal person, all 100 ml is filtered. But in a patient with partial renal failure, suppose filtration fraction become 50%. So out of 100, only 50 ml of blood is filtered. So that will lead to oliguria. Urine outflow decreases. So filtration fraction has become 50%. So due to that, the urine output decreases. So what mannitol do? We know mannitol exert osmotic effect. So it exert osmotic effect in all parts of the body, and from every part it will bring some blood, because when mannitol comes in the blood, it will attract the water toward it. So blood coming out of the organ will contain more water. So mannitol does this in all the organs. So from every organ the blood start coming toward kidney. So amount of blood which is filtered will be more. So when we give mannitol, instead of 100, now 200 ml of blood is coming. And if 50% is filtered, so 50% of 200 is 100. So that means urine outflow normalizes. So that means incipient renal failure can be treated. Simple reason is it increases the renal blood flow. More amount of blood comes in the kidney. So when more is coming, even if lesser percentage is filtered, urine outflow normalizes. Clear? But mannitol is contraindicated in complete renal failure. Complete renal failure, we can say acute renal failure, mannitol is contraindicated because in complete renal failure, the filtration fraction will be 0. Even if 200 or 500 ml blood come, it cannot be filtered. So that means it cannot improve the urine outflow. Rather, it is attracting the blood from all parts of the body, and that will increase the edema. Clear? So it is contraindicated in acute renal failure, used in incipient renal failure, but contraindicated in acute renal failure. Clear? Now, if we revise the important points regarding mannitol, what are the important uses of mannitol? Yes, mannitol is used for glaucoma, angle closure glaucoma, particularly during acute attack, acute congestive glaucoma. It is used in cerebral edema, and just now we discussed it is used in incipient renal failure, or simply we say partial renal failure. These are the important uses of mannitol. And similarly, we can discuss the main contraindications or adverse effects of mannitol. Contraindicated in cerebral hemorrhage. If edema is due to cerebral hemorrhage, then mannitol is contraindicated. We just discussed it is contraindicated in acute renal failure, complete renal failure. And lastly, it is contraindicated in pulmonary edema, or we can say left ventricular failure. The again reason is same. In pulmonary edema, already the heart is not pumping properly. That's why pulmonary edema occurs. So when we give mannitol, it will increase the blood from all parts of the body. That means more blood comes in the heart. So when more blood is present in the vascular compartment, preload increases, and preload increases, that will worsen the condition. Clear? So these are the important uses and contraindications of mannitol.
Now, what will happen if we give mannitol orally? Yes, it will do same thing. It will attract water in the GIT, that will lead to diarrhea. So if we give oral mannitol, it will cause osmotic diarrhea. So these are important points regarding the first of the diuretics, which is osmotic diuretic. It can work anywhere in the nephron. Coming to number 2, diuretic working on proximal tubules. Second group of diuretics are carbonic anhydrase inhibitors. These act on proximal tubule. First of all, what happens in proximal tubule we will like to discuss. This is the lumen of the proximal tubule. This is cell in the proximal tubule. And here is the blood side. So glomerulus filters sodium and bicarbonate, and they come in the lumen. Sodium and bicarbonate are filtered and they come in the lumen of the nephron. In the proximal tubule, there is presence of a transporter called as sodium hydrogen antiporter. That means it takes up sodium in the cell, and in exchange it will remove hydrogen ions. So sodium hydrogen antiporter. Now these hydrogen ions, they react with bicarbonate to produce carbonic acid. This carbonic acid spontaneously breaks into carbon dioxide and water. Both these reactions are catalyzed by a carbonic anhydrase enzyme. Now this carbon dioxide and water which are produced, they are freely permeable, so they easily enter inside these cells. So carbon dioxide and water enter inside these cells, and in these cells they again react to form carbonic acid. This carbonic acid again breaks to bicarbonate and protons. Both these reactions are again catalyzed by carbonic anhydrase. Now the protons which are produced, they are exchanged with sodium via sodium hydrogen antiporter, whereas the bicarbonate which has entered the cell along with the sodium which has entered from sodium hydrogen antiporter, they will be transported to the blood with the help of another transporter here, which is transporting sodium and bicarbonate. So sodium and bicarbonate, they will enter the blood. So basically what is happening is, sodium and bicarbonate which are filtered by the glomerulus, it has entered in the blood. And this entry in the blood is because of functioning of carbonic anhydrase enzyme. So if we inhibit the carbonic anhydrase, sodium and bicarbonate will not be reabsorbed. So in simple language, carbonic anhydrase inhibitors will cause loss of sodium and bicarbonate in the urine. So when sodium is lost in the urine, along with that water follows. So it will produce diuretic effect. Whereas loss of bicarbonate will make the urine alkaline because more bicarbonate is present in the urine. So urinary alkalosis may occur. And when bicarbonate is lost in the urine, it will be less in the blood. So that can result in metabolic acidosis. Because these drugs can produce metabolic acidosis, so these drugs have self-limiting action. That means kidney will automatically stop filtering the bicarbonate. So these have self-limiting action. They are not very powerful diuretic agents. The main drug in this category is acetazolamide. Whereas two more drugs are available. These are brinzolamide and dorzolamide. Both these drugs are topical drugs only. They are used as eye drops for glaucoma. Whereas acetazolamide can be given orally or by injectable route.
Carbonic anhydrase inhibitors, they are non-competitive but reversible inhibitor of the enzyme carbonic anhydrase. Normally non-competitive inhibitors are irreversible, but carbonic anhydrase inhibitors are non-competitive but reversible inhibitor of the enzyme. Now we will move to the important uses, side effects and contraindications of carbonic anhydrase inhibitors. First of all, coming to indications or uses. So uses of carbonic anhydrase inhibitors we can remember from game. G for glaucoma. Carbonic anhydrase inhibitors are used in angle closure glaucoma. Then A for alkalinization of urine. We know carbonic anhydrase inhibitor, they secrete bicarbonate in the urine, and when more bicarbonate is present in the urine, it become alkaline. So they can be used to make the urine alkaline, as in case of drug poisonings. Then M for mountain sickness. Carbonic anhydrase inhibitors, they are drug of choice for treatment and prophylaxis of acute mountain sickness. We'll try to understand what is the mechanism of these drugs in mountain sickness. We all know mountain sickness occurs at very high altitude. Like we go to Leh, Ladakh, at very high altitude, person develop dyspnea, which is called mountain sickness. What is the problem at high altitudes? Yes, there is lesser partial pressure of oxygen, or in simple language we can say oxygen is less in the environment. So to take up enough oxygen, what the person do is person start hyperventilating. So at high altitudes hyperventilation occur, so the person takes up more oxygen to meet the metabolic demand of the body, takes more oxygen and in exchange removes more carbon dioxide. So what happen is, due to hyperventilation, more carbon dioxide is removed from the body. And we know carbon dioxide, it is required for maintaining the medium acid. So we know carbon dioxide, it combined with water to form carbonic acid. So carbon dioxide form acid. So it is required to make the blood acidic, slight acidic. But when carbon dioxide is lost, so the blood will become alkaline. So simple language, the person will develop respiratory alkalosis. So the main problem in mountain sickness is person develop respiratory alkalosis due to hyperventilation. So what carbonic anhydrase inhibitors do? Yes, they cause loss of bicarbonate in the urine. They cause loss of sodium and bicarbonate. So when bicarbonate is lost in the urine, the blood will become normal. Instead of alkaline, it become normal. So when respiratory alkalosis do not occur, the person's symptom will not appear. Okay? So carbonic anhydrase inhibitors like acetazolamide, it is drug of choice for acute mountain sickness. Lastly, we can use these drugs in epilepsy also. Although nowadays we have better anti-epileptic drugs, so these are not commonly used. Clear? So these are the important uses of carbonic anhydrase inhibitors. Now coming to adverse effects of carbonic anhydrase inhibitors. Carbonic anhydrase inhibitors, they can cause paresthesias. This is very commonly asked in the exams. Which diuretic can result in paresthesia? It is carbonic anhydrase inhibitors. Apart from paresthesia, carbonic anhydrase inhibitors increase the risk of kidney stones. Increase the risk of stones in the kidney. Basically, calcium gets precipitated in the alkaline medium. So when we give carbonic anhydrase inhibitor, the urine become alkaline because bicarbonate is lost in the urine. And when urine become alkaline, then more risk of precipitation of calcium occurs, so stones can occur. Now, any drug which possesses carbonic anhydrase inhibitory property, they can result in renal stones. Like in the anti-epileptic drugs we discussed, like topiramate, zonisamide, they can cause renal stones because they have carbonic anhydrase inhibiting property. Then third and the most important side effect is hypokalemia. Like most of the diuretics, they can cause hypokalemia, but special point to remember is among all the diuretic agents at equally natriuretic doses, that means at same doses at which equal amount of sodium can be removed from the body, carbonic anhydrase inhibitors cause maximum hypokalemia. If we give same doses, one thiazide, one loop diuretic, one acetazolamide, the doses are such that they will cause equal loss of sodium from the body, equally natriuretic doses, then carbonic anhydrase inhibitors have maximum hypokalemia causing potential. Clear? Lastly, carbonic anhydrase inhibitors are contraindicated in liver failure. Now, why they are contraindicated in a liver failure? If a person is having liver failure, the ammonia which is normally converted by liver to urea, this will not happen because liver is failed. So ammonia cannot be converted to urea. So this ammonia can go to brain and it can result in coma, which is called as hepatic coma. Carbonic anhydrase inhibitors, they will increase the risk of hepatic coma. Now, how they increase the risk of hepatic coma is, in a normal person, ammonia can be converted to urea by liver, but in liver failure, ammonia cannot be converted to urea. So now the kidneys take the responsibility of removing the ammonia. So how kidneys remove the ammonia is, ammonia is filtered and comes in the tubules. We know ammonia is non-ionized, so it can be reabsorbed back because it is lipid soluble. But whenever ammonia comes in the urine, because of slightly acidic nature of the urine, we have free protons available in the urine. So ammonia combined with these free proteins to form ammonium ions. And we know ionic form is a tertiary compound, means it cannot cross the membrane. So this ammonium ion, they will be excreted in the urine. So ammonia now has been removed from the urine, so there is no problem of coma. But if we give any drug which make the urine alkaline, like carbonic anhydrase inhibitors, so if the urine become alkaline, these free protons will not be available. So when free protons are not available, the ammonia will remain as NH3. It will not be converted to ammonium ion. So when it is available as NH3, means it is non-ionized, so it can be reabsorbed, and that increases the risk of coma. Clear? So carbonic anhydrase inhibitors are contraindicated in liver failure.
So second group of diuretics we just finished, they act on proximal tubules and the drugs are carbonic anhydrase inhibitors. Now third group of drugs, they act on loop of Henle. So they are called as loop diuretics.
These drugs, loop diuretics, they work on thick ascending limb of loop of Henle. Now important to recognize, so this we all know is glomerulus, proximal tubule, and then loop of Henle. So loop of Henle, it is present like this initially, and then it becomes thick. So then it is collecting duct. So basically there are two limbs of loop of Henle, descending limb and ascending limb. In the ascending limb we have two parts, thin ascending limb and thick ascending limb. So loop diuretics, they work on thick ascending limb of loop of Henle. This is asked in the exam, exactly on which part of the nephron it works. It works on thick ascending limb of loop of Henle. Here sodium potassium 2 chloride pump is present, which is inhibited by loop diuretics.
Now the ascending limb of loop of Henle, it contains a transporter which transport three substances: sodium, potassium and two molecules of chloride. So sodium potassium 2 chloride symporter help in absorption of these substances. Loop diuretics work by inhibiting this pump, sodium potassium 2 chloride pump. So when sodium is not absorbed, it will be excreted in the urine, and that will produce the diuretic effect. The main example of loop diuretics are furosemide, torsemide and bumetanide. Loop diuretics are known as high ceiling diuretics. So high ceiling diuretic simply means high efficacy diuretics. The meaning of this term is loop diuretics can cause loss of large amount of sodium and water in the urine. If we give less dose, they can remove 500 ml of urine. If we increase the dose, they can remove 1 liter of urine. If we increase the dose further, they can remove 2 liters. They can remove 5 liters, they can remove 10 liters. That means their ceiling is very high. Ceiling is very high. That means we keep on increasing the dose, the effect keep on increasing. On the other hand, the another major group of drug like thiazides, they have low ceiling. That means even on increasing the dose, the effect do not increase very much. Now why loop diuretics are having high ceiling is, this is the area of the nephron loop of Henle where around 20 to 25% of sodium is reabsorbed. So when we inhibit this reabsorption, then most of the sodium will be excreted, because distal to this the reabsorptive capacity of the nephron is very less. On the other hand, if we give carbonic anhydrase inhibitors, although around 60 to 65% of sodium is reabsorbed in the proximal tubule, but carbonic anhydrase inhibitors, they inhibit the reabsorption of sodium there, but most of that can be reabsorbed in the distal portion of the nephron. Reabsorptive capacity is quite high. Further, because of production of metabolic acidosis, they have self-limiting action. On the other hand, the diuretic which act distal to loop, like the diuretic acting on distal tubules or collecting ducts, there most of the sodium would have already been absorbed. Around 5% sodium will reach those areas, so they will not have very high efficacy. So loop diuretics have high ceiling effect, so they are high efficacy diuretics.
Now moving to uses of loop diuretics. We know loop diuretics are very strong diuretics, so they can be used in cases of edema like left ventricular failure, pulmonary edema. We can remove the fluid by giving loop diuretics. They can be used in hypertensive emergencies. They cause sudden removal of sodium and water from the body, so suddenly they can decrease the blood pressure. So hypertensive emergency, we can use loop diuretics. We discussed loop loses calcium, so they cause loss of calcium, so that means they can be used for treatment of hypercalcemia. For treatment of hypercalcemia, we can use loop diuretics. Apart from this, Loop diuretics are also used in bromide and iodide poisoning. Basically, loop diuretic inhibits sodium potassium 2 chloride pump. If you remember, in the loop of NLA, there is presence of a pump which help in absorption of three substances: sodium, potassium, and 2 chloride. And through the same pump, the other halides like chlorine, we have iodine, bromine, the other halides of the periodic table, they are also absorbed from same pump. So when we give loop diuretic, they will inhibit this pump. So bromide and iodide will not be absorbed. So they will be excreted in the urine. So poisoning can be treated. Clear?
First, we will discuss about diuretic act on distal tubules also. Then we will discuss the adverse effect and properties of both the diuretic together. So number 4 diuretics are diuretics acting on distal tubules, and chemically these are thiazides. In the distal tubules, there is presence of another pump which is called sodium chloride symporter. Distal tubules contain sodium chloride symporter, so they help in absorption of sodium and chloride. Thiazides act by inhibiting these transporters. The examples of thiazides: any drug which end with thiazide like hydrochlorothiazide, methiazide, polythiazide, chlorothiazide. So any drug ending with thiazide are thiazide diuretic. Now there are some more drugs which do not end with thiazide, but they also act by same mechanism, like indapamide, zepamide. These are also same mechanism, having same mechanism. So these drugs which are chemically different but produce same effect, they are called thiazide-like diuretics. Because chemically they are not thiazide, but they are working like thiazide. So this is mechanism of thiazide diuretics. Now coming to common properties of both loop and thiazide diuretics. We discussed earlier also, both loop diuretics as well as thiazides, they cause loss of all the ions from the kidney. That means they cause loss of sodium, loss of potassium, loss of magnesium, and loss of hydrogen. Means they can cause hyponatremia, hypokalemia, hypomagnesemia, and metabolic alkalosis. It is caused by both loop diuretic and thiazides. And both of them cause increase in metabolic substances. Both of them cause hyperglycemia, hyperuricemia, and hyperlipidemia. So both loop diuretics and thiazide can cause hyperglycemia, hyperuricemia, and hyperlipidemia. So most of the actions are same. The major difference between the two is effect on calcium. One increase calcium and second decrease calcium, and that fact you can remember as loop loses calcium. That means loop diuretic cause loss of calcium, means it will decrease in the blood, hypocalcemia. On the other hand, thiazides are opposite, they cause hypercalcemia. So loop diuretics cause hypocalcemia, thiazide cause hypercalcemia. Now because loop diuretics are causing hypocalcemia, they can be used for treatment of hypercalcemia. In treatment of hypercalcemia, we can use loop diuretics. On the other hand, thiazides are increasing calcium in the body, so they can be used for osteoporosis. So which diuretic will you like to use in a patient with recurrent renal calcium stones? A person has a problem in which again and again stones are formed in the kidney. Calcium stones are formed in the kidney. So which diuretic will you like to use? No. If you see, this is the blood and this is the kidney. So we discussed loop loses calcium. That means loop diuretic will cause loss of calcium in the kidney. So that's why the calcium will decrease in the blood. But if you see, the stones are getting formed in the kidney. So if more calcium is excreted in the kidney, the stone formation will rather increase. So it is very important to remember, although loop diuretics are causing loss of calcium, but they are decreasing the calcium in blood, not in kidney. Thiazides we discussed have opposite effect. That means they prevent the loss of calcium in the kidney. That's why more calcium will be retained in the blood. But what is happening is less calcium will go to kidney. So when less calcium goes to kidney, there will be less risk of stone formation. So that's why we use thiazide for renal stones, not loop diuretics. Although it seems paradoxical that thiazides are increasing the serum calcium, but still we are using them in calcium stones. But if we understand the mechanism that they increase serum calcium by preventing the movement of calcium into the kidney, then we can easily correlate that when calcium is less in the kidney, there will be less risk of stones. So thiazides are used in renal stones. Main uses, which is in cases of edema, both the diuretics can be used for edema. Another important use of these drugs is hypertension. Thiazides we discussed in cardiovascular system are drug of choice for hypertension. Now one very important use of thiazides, which is again a paradoxical use, thiazides are used for diabetes insipidus. Thiazides are used for diabetes insipidus. So for understanding, first we need to know what is diabetes insipidus. From the hypothalamus, posterior part of the pituitary, there is a release of anti-diuretic hormone. What is the function of anti-diuretic hormone? To retain sodium or to retain only water. So anti-diuretic do not retain sodium and water. Anti-diuretic hormone, the function is to retain only water. Anti-diuretic hormone retains only water. And this is secreted whenever there is hemo concentration, whenever we want to retain water only, so that it will dilute and plasma osmolarity become normal. So hypothalamus secrete ADH that will act on the kidney. It will act on the kidney to retain water. Now, if ADH is not released by the hypothalamus, ADH is not present, then water cannot be retained. The person will develop polyuria. So the condition is known as diabetes insipidus. So this type of diabetes insipidus, which is due to less ADH release from the brain, is called central diabetes insipidus. On the other hand, if ADH is released but it is not able to work on kidney, there is problem in kidney, then it is called nephrogenic diabetes insipidus. So diabetes insipidus may be central, it may be nephrogenic. Now for central diabetes insipidus, we have to give ADH because ADH is not coming. So instead of ADH, we will use a better version of ADH, which is called desmopressin. Desmopressin, it is drug of choice for central diabetes insipidus. On the other hand, desmopressin will not be effective in nephrogenic diabetes insipidus because when ADH is already present and it is not able to produce the effect, the exogenous ADH will also be not ineffective. So in nephrogenic diabetes insipidus, we can utilize thiazides. So how the thiazides work? Remember, thiazides are diuretics, and in this person already there is more urine outflow. So how thiazides will work? Now, there are many possible mechanisms. The most important mechanism which can explain why thiazides are producing anti-diuretic effect. So what is happening in diabetes insipidus patient is, these patients have polyuria, and polyuria is very severe. So the person is excreting around 100 to 200 liters of water daily. The question is, from where this much amount of water comes in the body? We have only 5 liters of water in the body. So how come a person will excrete 100 liters of water in the urine? So what happens is, in these patients of diabetes insipidus, ADH is not working. So water cannot be retained. So when water is not retained, the plasma become hyperosmolar. So plasma hyperosmolarity increases. Now whenever plasma osmolarity increase in a normal person, we have two mechanisms to compensate. One, there is release of ADH from the hypothalamus so that water can be retained. So osmolarity become normal. Second, the thirst center is stimulated in the brain, so the person can drink more water. When more water is drunk, then the osmolarity will decrease. Now what thiazide do is, thiazide cause excretion of the concentrated urine. Remember, thiazide work on distal tubules, and distal tubule of the nephron is also known as cortical diluting segment. That means function of this part of the nephron is to dilute the urine. So when we inhibit this part, urine cannot be diluted. That means the amount of urine which goes out, 3 to 4 liters, slightly more urine goes out, but that is concentrated. So when concentrated urine is passed out, the plasma osmolarity will decrease. When plasma osmolarity decreases, there will be decrease in thirst. When thirst decrease, person drink less water. And when the person drink less water, there will be less urine formation. Remember, in patients with diabetes insipidus, this mechanism is interfered. So because of increase in osmolarity, person keep on drinking. When person keep on drinking, there is more urine outflow also. But when we give thiazide, it decreases the plasma osmolarity by causing removal of concentrated urine, and that will lead to decrease in thirst. And when the person drink less water, there will be less urine outflow. So that is mechanism of thiazide in diabetes insipidus.
So the uses of thiazides include hypertension. These are first line drugs in treatment of hypertension. Although not very strong, but they can be used in patients with edema. They can remove little bit of sodium and water from the body. Then we discussed loop loses calcium, whereas thiazide retain calcium. So because they are retaining calcium, thiazide can be used in osteoporosis. Further, we can use them in treatment of renal stones. Remember, we discussed thiazide retain calcium, so less calcium will go to kidney, so there will be less chances of formation of stones. Although it is paradoxical that the person is already having calcium stone in the kidney, still we are giving a drug which is retaining calcium. The reason is simple, it is retaining calcium, so calcium cannot go to kidney, so there the stone will not form. Okay, then just like loop diuretics, thiazide can also be used for bromide and iodide intoxication. So in the distal tubule, sodium chloride pump is present, through which chloride is absorbed. So through the same pump, bromide and iodide can also be absorbed. So we can inhibit this by thiazide, so poisoning can be treated. And lastly, thiazides can be used for diabetes insipidus. They are useful in both nephrogenic as well as central diabetes insipidus, but in nephrogenic diabetes insipidus, thiazides are drug of choice. Okay,
with that we completed the fourth group of diuretics, which are thiazides. Now the last group of diuretics, they work on collecting ducts, and these diuretics are known as potassium sparing diuretics. What happens in collecting duct is, this is a collecting duct, this is cell of collecting duct. In the collecting duct, there is presence of 3 separate transporters. One help in absorption of sodium, second help in excretion of potassium, and third help in excretion of hydrogen. Now, although we have three separate pumps, but the boss of these pumps is sodium. That means sodium help in removal of potassium and hydrogen also. Now, all three pumps, they are stimulated by aldosterone. So there is presence of aldosterone receptors. So when aldosterone comes, it stimulates these receptors, and when these receptors are stimulated, all three pumps keep on working. So when all three pumps work, sodium is absorbed, potassium and hydrogen are excreted. Now the drugs which act at collecting duct, they may be of two types. One, the drug may block the aldosterone receptor antagonist, and second, the drug may block the epithelial sodium channel. So we have two type of drugs. One is aldosterone antagonist, second is epithelial sodium channel blocker. The final effect of both of them will be same, because when we block aldosterone receptor, all three pumps will stop working. On the other hand, if we block sodium channel, other two pumps will also stop working, because sodium was the main channel which help in working of potassium and hydrogen channels also. So the two type of drugs which act on collecting duct, one is aldosterone antagonist, second is epithelial sodium channel blocker. The drugs which are aldosterone antagonist are spironolactone, and eplerenone. Whereas drugs which are epithelial sodium channel blocker are amiloride and triamterene. Final effect of both the drug groups will be same. Sodium will not be absorbed, so there will be loss of sodium and water in the urine, so they are diuretic drugs. Potassium cannot be excreted, so they will retain potassium. That's why the name potassium sparing diuretics. And hydrogen cannot be excreted, so it will remain in the body, so that lead to metabolic acidosis. So these drugs can cause a diuresis, hyperkalemia and metabolic acidosis. And the name of the drugs you can remember from the mnemonic paste. Potassium sparing diuretics are P for potassium. Potassium sparing diuretics are A for amiloride, S for spironolactone, T for triamterene, and E for eplerenone. And we all know that spironolactone cause gynecomastia, and this side effect is absent in eplerenone. Although both are potassium sparing diuretic, aldosterone antagonist, spironolactone cause gynecomastia, eplerenone does not cause this side effect.
Uses of aldosterone antagonists include Conn syndrome. Conn syndrome is a condition in which there is hyperaldosteronism. So more of aldosterone is secreted. So obviously if we block their receptors by giving spironolactone like drugs, we can treat the condition. So Conn syndrome or Cushing syndrome we can utilize there. Aldosterone antagonists are drug of choice for treatment of edema in cirrhosis. The simple reason is in cirrhotic patients there is compensatory increase in aldosterone secretion, so that will retain water which lead to edema. So we can treat it by giving aldosterone antagonists like spironolactone. Then these are called as potassium sparing diuretic. So these are commonly combined with other diuretics like thiazide or loop diuretics to prevent hypokalemia. So they are used to prevent hypokalemia by other diuretics. we discussed in the cardiovascular system, there is left ventricular hypertrophy, or we can say cardiac remodeling due to aldosterone. So aldosterone antagonists like spironolactone, they can reverse the left ventricular hypertrophy seen in congestive heart failure. And lastly, spironolactone like drugs, they can be used for resistant hypertension. For resistant hypertension which cannot be treated by other drugs, we can add aldosterone antagonists. Now the last thing to understand here, why different diuretics cause hypokalemia. If we see loop diuretic inhibits sodium potassium 2 chloride pump, so we can assume they are inhibiting the reabsorption of potassium, so that can lead to hypokalemia. But thiazide inhibits sodium chloride pump, they do not inhibit potassium, still they cause hypokalemia. Carbonic anhydrase inhibitors also cause hypokalemia. So how they cause hypokalemia, in general mechanism we will try to discuss. If you see, this is the collecting duct. In the collecting duct, there is a reabsorption of effect on three ions. Sodium is reabsorbed, and in exchange potassium and hydrogen are excreted. Now assuming hypothetically, suppose in a normal person without giving any diuretic, at this area suppose 100 molecules of sodium reach in the collecting ducts and collecting tubules, the last portion. 100 molecule of sodium reach in this area, and suppose out of these 100 molecules, 40 molecules of sodium are normally reabsorbed. So 40 are reabsorbed, so how much will be excreted in the urine? 60 molecules. So if we see the normal values in the urine, 60 molecules of sodium are normally excreted in urine in our example. Now when 40 molecules of sodium are reabsorbed, so that means in exchange we have to give same number of positive charge also. So in exchange 20 molecules of potassium and 20 molecules of hydrogen are excreted in the urine. So how much potassium and hydrogen are excreted? So potassium is 20 and hydrogen is 20. So we have assumed that this is the normal scenario. So in a normal urine, 60 sodium, 20 potassium and 20 hydrogen goes. Clear? Now we give any diuretic. It may be loop diuretic, it may be thiazide, any diuretic. The basic purpose of diuretic is they inhibit the reabsorption of sodium. So more sodium can be excreted. So that means now the amount of sodium reaching the collecting tubules instead of 100, suppose is 200. So more sodium will reach because we have inhibited the reabsorption proximally. So 200 molecule have reached here. So when 200 molecules have reached, so more will be absorbed. So instead of 40, now we assume 80 molecules of sodium are reabsorbed. So when 80 are reabsorbed means how much is excreted in the urine? Rest of the 120 molecules. So after giving a diuretic agent, now 120 molecules of sodium are excreted in the urine. So we can safely say diuresis has happened, because earlier in a normal blood 60 sodium were excreted, now 120 are excreted, so diuretic effect has come. Clear? But when 80 molecule of sodium are reabsorbed, so in exchange half potassium and half hydrogen will go. So now in this person 40 potassium and 40 hydrogen will be excreted. So amount of potassium and hydrogen in the urine will be 40 each. Clear? So what happens, instead of 20, when 40 potassium are excreted, it leads to hypokalemia. Clear? So all the diuretic except those which act at this place in the collecting ducts, all the diuretic, they will increase the delivery of sodium to the collecting ducts. So more sodium will be reabsorbed, and in exchange more potassium will be excreted, which can lead to hypokalemia. Clear? Now second thing, normally these sodium which are reabsorbed, half of potassium and half of hydrogen are secreted. But if you see carbonic anhydrase inhibitors, they inhibit the enzyme carbonic anhydrase. So this carbonic acid cannot be broken to generate protons. So that means protons cannot be secreted. So that means all 80 molecules of sodium are exchanged with potassium only, because hydrogen cannot be generated. So that means in case of carbonic anhydrase inhibitors, all 80 potassium will be excreted. So that's why they cause maximum hypokalemia at equally natriuretic doses. Clear? And obviously if we inhibit this channel, then hypokalemia will not occur because potassium cannot go out, so potassium will be retained. That's why this group of drugs are potassium sparing diuretics. Okay.
Now last thing to remember, all the diuretics which we see, they are working from the lumen. If we give osmotic diuretics, they will come in the lumen, attract water, and that will lead to diuresis. If we give carbonic anhydrase inhibitors, they are filtered by the glomerulus, then from the lumen they will work in the proximal tubule to inhibit carbonic anhydrase. If we give loop or thiazide diuretics, they will be filtered by the glomerulus, then they will move through the lumen to the loop of Henle or distal tubules, where they will inhibit the transporters. Similarly, the amyloride and triamterene, they will be filtered by the glomerulus, come to the lumen, and then they will inhibit the sodium channel in the lumen. So all the diuretics are working through lumen except the aldosterone antagonist. Remember, aldosterone receptor is not in the lumen, it is on the basolateral side. So aldosterone antagonists, they will come from the blood and inhibit the aldosterone receptors. So aldosterone antagonists like spironolactone and eplerenone, they are the only diuretics which work from the blood side. All other diuretics work from the luminal side. So these are the important points regarding the diuretics.